Imagine you're in a bustling coffee shop. There's laughter and chatter, but suddenly your heart is racing and you're sweating. And the familiar sounds that were just surrounding you are now distant echoes, and you're struggling to stay upright because the floor is pitching, even though you're standing still. This has been happening to you a lot lately, along with fatigue, brain fog, heat and cold intolerance, light sensitivity, and maybe insomnia. But right now, the people around you are noticing you don't seem quite right, and you're beginning to internally panic. There is something very, very wrong. So, is this just a fainting spell or something way more insidious, like dysautonomia? All right, so dysautonomia is a condition that affects the autonomic nervous system, the system responsible for regulating our automatic bodily functions, functions that we do not have control over: breathing, heart rate, blood pressure, digestion, all controlled by the autonomic nervous system. I remember this by associating autonomic with automatic. These are functions that occur automatically in response to our environment or while we're at rest, also better known as fight or flight and rest and digest responses. So while we're sleeping, we're not concentrating on breathing or telling our heart to beat, it's just happening. Our body is also digesting food and doing temperature regulation, all without conscious effort on our part. But for those with dysautonomia, this system is faulty and it leads to a range of really problematic symptoms: excessive sweating, rapid heart rate, either while at rest or right after getting up to a standing position, widely fluctuating blood pressure, chronic fatigue, fainting spells, digestive issues. We're going to get into all of the specifics about what's going on and why this happens exactly, what conditions may predispose someone to dysautonomia, and more importantly, what can be done about it to manage the extremely uncomfortable and life-altering issues it causes. It can be debilitating, unpredictable, and isolating. And all too often, dysautonomia is dismissed and quite misunderstood. But why? Well, because unless you're experiencing it firsthand, it's virtually invisible. Symptoms are not always evident. So if you're around someone who has dysautonomia, you may recognize that something is off. Sweating in frigid cold weather, not sweating on very hot days, shakiness, instability, or dizziness when rising or standing for more than 10 minutes, profound weakness to the point that they need assistance walking or help with simple tasks. There's a fear of fainting in public, and there is also, due to this, a huge psychological component, because many times what's happening on the outside looks very different from what is being experienced on the inside. Ultimately, many sufferers deal with this burden for extended periods of time before they're officially diagnosed, and the mental and emotional tolls it takes are costly. All right, let's get into some facts. The first one is various forms of dysautonomia are relatively common, with more than 70 million people worldwide having some form of it. It could be something you're born with, or you can develop it really at any point, from late teens to early adulthood, and then again later in life, with an average age of onset falling between 50 and 60 years of age. Number two, other less common names for it include autonomic dysfunction or autonomic neuropathy. There are many different types of dysautonomia, some of which you may be familiar with, including neurocardiogenic syncope, postural orthostatic tachycardia syndrome, or POTS, which we'll get into in a little bit, inappropriate sinus tachycardia, orthostatic hypotension, and autoimmune autonomic ganglionopathy, to name a few. It can also occur secondary to other diseases like diabetes, small fiber neuropathy, Sjogren's syndrome, celiac disease, MS, and Parkinson's. So many dysautonomia patients experience years of diagnostic delay and have difficulty finding physicians to treat this condition because most doctors just haven't received adequate training on how to recognize or effectively manage autonomic nervous system disorders. There are two main types. Primary is when it happens on its own without a cause, and secondary is it happens because of another condition like we just mentioned above. So primary dysautonomias are not as common as secondary are. A specific example of a primary type of dysautonomia is an inherited form called familial dysautonomia. And being of Jewish heritage, especially Ashkenazi Jews, Eastern European descent, or having a first degree relative like a parent or a sibling with it can increase your odds. Another primary form is idiopathic dysautonomia, which means it happens for a reason that we as healthcare providers can't explain or detect, can't quite figure it out. Secondary dysautonomias can be caused by other diseases or worsened by other diseases. And they'll include, this is going to be a long list, but they'll include amyloidosis, amyotrophic lateral sclerosis or ALS, also known as Lou Gehrig's disease, botulism, brain tumors, complex regional pain syndrome, COVID-19, especially long COVID, Ehlers-Danlos syndrome, which is a connective tissue disorder, Guillain-Barré, lupus, Lyme's disease, hyperhidrosis, which is excessive sweating, rheumatoid arthritis, spinal cord injury, or exposure to toxins, poisons, or heavy metals like mercury, arsenic, or organophosphates found in pesticides, vitamin B12 deficiency, and postural orthostatic tachycardia syndrome, or POTS, which is a form of dysautonomia that prior to COVID-19 impacted an estimated 3 million Americans. But recent research shows that the number of POTS patients has now grown to an estimated 6 million Americans since the start of the pandemic. POTS is a specific form of orthostatic intolerance that is associated with excessive increases in heart rate and other symptoms upon standing. The current diagnostic criteria is a heart rate increase of 30 beats per minute or more, or over 120 beats per minute within the first 10 minutes of standing without a significant drop in blood pressure. So if you think about it like this, when we stand, it's an appropriate response for our heart rate to increase slightly in response to the body now needing to work against gravity to continue to move blood upwards towards the brain. And to clarify, regular orthostatic hypotension is when our blood pressure goes low when we stand up. And this tends to occur as we age because our bodies don't have the muscle tone that we used to keep blood moving without missing a beat when we change positions. Here, our heart rate may briefly increase, but not significantly like in POTS. POTS, on the other hand, shows a dramatic increase in heart rate without the drop in blood pressure with a position change or after standing for any length of time. So because dysautonomia affects vital bodily processes, there are many possible complications. Most of them revolve around symptoms when they're severe or disrupt usual routines and activities. And some of the more serious symptoms and complications generally include heart rate issues, either too fast, too slow, or an irregular heart rate. Sufferers can have any combination or all of them. Fainting, which can lead to injuries from falls, trouble breathing, and then disrupted digestion, which can lead to constipation, diarrhea, or other problems. And then disrupted kidney function, leading to urinary tract infections or incontinence. There are a few YouTube videos of people demonstrating how their body reacts when they go from lying down to standing by wearing a pulse ox. And you'll see as they stand, their pulse starts to get faster and faster. I can certainly see why this is a very scary thing and causes people to not want to go out at all for fear they're going to pass out or fall in public. And I'll link to them in the description. It is very interesting to see what sufferers go through and to hear their stories of what finally led to their diagnosis, which is what we're talking about next. So, how is dysautonomia diagnosed? Now, normally, a combination of methods and tests are used. Diagnosing dysautonomia is often partly a process of elimination. It involves determining how and when symptoms happen and finding the patterns that link them. But even experienced providers may find it challenging to diagnose because it can cause symptoms throughout your body that might not seem related at first. A common pitfall occurs when symptoms are linked to whatever underlying condition is causing the dysautonomia, but not realizing that the dysautonomia is also happening as a standalone diagnosis. For example, someone experiencing frequent high blood sugar, maybe prior to an official diabetes diagnosis, they can have tachycardia, they can get dizzy, they can sweat. So a doctor or an NP may connect those symptoms to what appears obvious, which is the high glucose. However, the symptoms continue even after the glucose levels are stabilized. Or someone having a lot of GI upset with celiac disease, say, and as a result, they're not eating or drinking enough. The weakness and the bowel changes may be initially linked to the gluten intolerance and not the dysautonomia. This is why it gets missed for so long. Some of the tests that may help with diagnosing it or ruling out other conditions include a thorough physical and neurological exam, a tilt table test, which shows how your body responds to standing up after lying down. So there's fabric straps that keep you from falling off the table if your blood pressure drops. And we monitor your vital signs while the table tilts at various angles, allowing us to see why you faint and when you faint. On average, the test takes about 90 minutes. We can also do an electrocardiogram or a 24-hour Holter monitor, which just looks at your heart rate and rhythm. Sweat tests like the quantitative sudomotor axon reflex test, or QSART for short, which involves a mild electrical stimulation on the skin called ionophoresis, which triggers acetylcholine to stimulate your sweat glands. And it specifically looks at the volume of sweat produced by the stimulation. Another test, pupil measurement testing, or pupillometry, which is just a measure of pupil dilation. Ultrasound and other tests for symptoms related to urinary incontinence can also be done. Blood tests, especially antibodies that might indicate an autoimmune disorder, or testing levels of certain neurotransmitters like catecholamines, adrenaline, noradrenaline, etc., and whether those levels are appropriate. And a 24-hour urine is sometimes done to determine if there are low urinary sodium levels after a 24-hour period. An additional 24-hour urine collection may also be carried out to test for high levels of noradrenaline and epinephrine to rule out pheochromocytoma, which is a growth on the adrenal glands, as a possible cause of symptoms. So the average time to diagnosis is about 6 years from when symptoms start. Only 25% of patients are diagnosed within the first year, and 50% of patients travel more than 100 miles from home to receive appropriate medical care for this condition. There are POTS treatment centers. Johns Hopkins is one of them. There are also doctors who specialize in the treatment of POTS, such as Dr. Tae Chung, who runs the POTS program at Hopkins. So how is dysautonomia treated, and is there a cure? There is no cure for dysautonomia, but many symptoms are manageable. The treatment approach for it depends strongly on many factors, especially what's causing it. Some treatments that may help include diet and hydration changes. So We like to increase fluid intake to about 2 to 3 liters a day, and also increase salt consumption to about 3,000 to 10,000 milligrams a day. So this helps maintain blood pressure. I mean, if you think about it, usually with cardiac issues or blood pressure issues, peripheral edema, swelling, we try and have them stay away from the salt, and we monitor that very closely. But somebody with dysautonomia, it's the exact opposite issue. It's a different problem. But one of the reasons that dysautonomia is so tough to manage sometimes is because there can also be underlying conditions. It's a very, very difficult thing to treat. So you definitely want to seek out a doctor who has a lot of experience treating this condition, because it can be tricky. You can also wear compression stockings. They will help raise the blood pressure and keep the blood flowing in one direction towards the head and stop it from pooling in the legs and feet. Raising the head of the bed to conserve blood volume is also another big help. You should also exercise, but if you have these issues or you feel unstable, then you need to obviously take this into account when you're choosing an exercise regime. Maybe reclined exercises like rowing or recumbent bicycling and swimming. Medications are used also to increase blood pressure, such as fludrocortisone, beta blockers, midodrine, clonidine, pyridostigmine, benzodiazepines, erythropoietin, which stimulates red blood cell growth in the bone marrow, and octreotide, which lowers growth hormone, which can be a factor with this as well. And then we have immunosuppressing medications or other immune system treatments, such as IVIG, which can treat dysautonomia associated with autoimmune conditions. So when dysautonomia occurs because of a medication or a medical treatment, stopping that medication or reversing that treatment is usually a priority. If an underlying cause of POTS symptoms can be identified, treating that underlying cause is obviously key as well, because there are so many facets to this condition and possible treatments. Your healthcare provider is the best source of information about your treatment options, and they can provide details that are most relevant to your situation and needs. They can also tell you about possible side effects and complications to watch out for and what you can do to limit or avoid those. So let's raise awareness and understanding by liking, sharing, getting this video out, because this is one of those conditions that has a huge mental health component as well. And this is one of the situations where a lot of times gaslighting will come into play. A lot of times people who suffer with dysautonomia get accused of being anxious or have a diagnosis of chronic anxiety or chronic depression. Not to say that those two things don't go hand in hand. Very often with all autoimmune diseases, you have anxiety and depression components. I mean, it's only natural. But with dysautonomia, and it's very much like fibromyalgia, because the symptoms are not front and center or, as specific as some other conditions or as profound, they don't present the same way. It's very easy for doctors to say, oh, they're just an anxious person, they're complaining a lot, they're a hypochondriac. So a lot of this type of situation often gets labeled as anxiety, chronic anxiety. And that's one of the reasons why these people just kind of give up and they just deal with it as best they can until they finally find a provider who understands this and is willing to do the testing and figure out, is it in fact dysautonomia? Is there an underlying condition here that is causing these symptoms? Maybe running into a few of these patients in practice where the puzzle pieces just aren't quite fitting, that they then become more familiar with picking out the signs and symptoms here. So again, huge mental health component associated with this. Again, just like fibromyalgia, can't see it. Sometimes people just are accused of being depressed, anxious. So check out our video that we did on medical gaslighting and what you can do to recognize it, the steps you can take to prevent it, and how to deal with it if it's happened to you. Just never give up searching for a diagnosis if you are not feeling well, if you've been chronically ill. If you would like a topic covered, just drop me an email at Danielle@lucidmed.com. Drop me a comment. I respond to all comments. I love getting them. I love hearing from you. I will say, please be respectful. I am respectful. I appreciate everyone being respectful in the comments. Every now and then I'll have a viewer that, it's just kind of, and I see all these comments. I note them. Depending on what they are, I will remove them. I'll be quite honest. I have zero tolerance for any of that on this channel. This is for sharing information and shedding spotlights on disease and chronic illness that maybe there wasn't a lot of information about, and coming together as a community to support each other. So the few people that can't find it in themselves to do that respectfully, properly, with empathy, you're not welcome. I hope I don't have to say that too often. But anyway, I will see you all next Sunday. Can you hear the dog snoring? I don't know if I'm going to be able to. You may hear snoring at the end of this. She's snoring, man. Anyway. All right, do I need to do that again, or can we just pick up where we left off? Okay. Oh, my face is so itchy. Doesn't that mean I'm going to have a fight? I think my grandmother always used to say, if my nose is itchy, I'm going to have a fight or kiss a fool. So which is that going to be? I can bet which one it's going to be. Let's see. Anyway. So the average time to diagnosis is about 6 years from when symptoms start. Why can't I say that? Is she on the couch? Coco, you better not be on that couch. She's on the couch. She's totally on the couch.